So I'll try to keep my talk limited to the evidence that is available for present research and to give new horizons to people who are interested in doing further research on dry eye, especially regarding the newer molecules that are available. So coming to my topic, no financial interest here. And this is my source of collecting this information because in my limited experience I could not have done all that has been described. So what can be called conventional has been published by AIOS in this 2013 publication, and what can no longer be called current research is use of tear osmolarity, biomarkers and lipiview. Most of our centers are doing it, and therapeutic agents like topical cyclosporine, autologous serum, osmoprotectants, omega-3 fatty acid, low-dose doxycycline and N-acetylcysteine. But there are still unanswered questions that can we universally recommend these quite expensive tests to all our patients. And when we come to therapeutic concerns, questions like topical cyclosporine, can it be used as a first line agent rather than using tear substitutes? Regarding autologous serum, ma'am has already discussed it. And omega-3 fatty acids, quite an expensive option. So can our diet modification alone give the benefits that are accrued from omega-3 fatty acids? And still, every time you open a journal, there are new researches which keep popping. So regarding the understanding of the pathogenesis, the role of neural secretion in form of corneal nerve density has been described. There has been a recent finding of association between dry eye syndrome, depression and anxiety, significance of polar mebum and tear lipids, the effect of visual display units. Like we were discussing the computer vision syndrome, there are so many new things which are coming in. Ocular and nasal immune system, we are now even discussing what our ENT colleagues are doing. And coming to the diagnostic role of high resolution OCT in measuring the tear meniscus or the role of pro-inflammatory biomarkers. And this is the one which is most interesting for if anybody is into research. Topical tacrolimus coming in big way. There were almost 4 papers in this AIOS. Role of ribamipide, it's a GI protectant extensively used by the Japanese. Role of diclofosol, many of our Indian colleagues are using it. Topical interleukin-1 receptor antagonist. Tofacitinib, which is a Janus kinase inhibitor. Lifitegrast, which is an integrin antagonist. A newer NSAID known as pranoprofen. The tear-mediated nanoparticle delivery. Nanoparticles are something which are going to hit us in a big way in another 4 to 5 years. Use of lid sprints, and something as unique as an abdominal breathing exercise which has been found to increase the tear production. So coming to the unanswered questions on conventional approach. So we went through all these articles, and as recent as 2014, when we discussed about the status of cyclosporine, they have said that randomized controlled trials with larger sample sizes are required to make a universal recommendation on the use of topical cyclosporine. All our major centers of excellence recommend it, but as a step 2 after tear substitute. So what we have not gone into the research yet is that can we use it as a step 1? Can we use it as a monotherapy? Because most of the papers, when you read through them, they talk about topical cyclosporine was given in adjunction to the tear substitutes. And what about still lower concentration of these drugs? Can we use even further lower concentration in the milder dry eye? And other calcineurin inhibitors which had not been promoted till now, something like tacrolimus, to brand it as a drop has not been done. Coming to tear osmolarity measurement, though thought of as an excellent, unique method, a one-step solution, but again, a 2014 paper says that they found in a very large number of cases an inability to distinguish between dry eye and healthy patient. Their sample size was significant. So we may not have a one-step solution yet. And is lipiview necessary? This is one thing where we also at least found that in most of the major centers of excellence, this is being used. Though it is not necessary, it adds objectivity to our findings in meibomian gland disease. And if you are practicing, it's a very important tool to increase patient compliance because you are giving him a visual image of his problem. So people agree that what about the LipiFlow, the next step to this? There is a convenience of a single 12-minute treatment with LipiFlow. and it has been found to be as effective as a 3-month regime by the patient, twice daily lid margin hygiene. So for most of our patients who are very busy in their lifestyle, this may be a boon. Coming to the role of MMP9 inhibitor markers. So there is something called inflamma-dry. I don't know how many of you have seen. I have at least not seen in my experience. But people say that it gives earlier diagnosis and more appropriate treatment. That when should we start introduction of anti-inflammatory drugs? So that question can be answered by use of this particular test, not very expensive when you consider cyclosporin continuing for 3 to 4 years. And a positive agreement of 81% and a negative agreement of 98% in this test. Talking about other biomarkers, lactoferrin and IgE, they had both come and now they are vanishing through most of the articles because they have only been claimed as complementary to inflamma-dry, that is the MMP9 inhibitor, and not alone to be of much significance. Omega-3 fatty acids, this is an expensive adjunct to the treatment. Though they have a definite role in higher doses in blepharitis and meibomian gland disease has been accepted now. Talking about low-dose doxycycline. Most of us love to use doxycycline in our patients of meibomian gland disease, but we give 100 milligram per day, which is gastrotoxic. I have used it myself, not a very happy drug. A 20 milligram alternative is available. These are the brands which we have shown. And now talking about our sojourn into the unexplored territories. I'll start with corneal nerve density. As I was talking about, neural inflammation is something coming up in a big way when we think of the tear film as a single unit rather than into separate subunits. So people found that patients who responded to treatment, their subbasal corneal nerve fiber length also increased, the density increased. So in future researches, we may look at it when we assess the outcome of a treatment. And depression and anxiety. These are few things when, as it was being said, that we have to counsel our patients. So we must remember that our patient sometimes may need to see a psychiatrist. Also, we have to look at the patient as a whole. So an association between dry eye disease and each of depression and anxiety in a study including 460,000 patients was found. So this is a very important thing in our practice. There is something called Osaka study being done regarding the effect of visual display units, and they have found that tear breakup time will be the correct parameter to follow when we think about impact of visual display unit on our patients. There was something which was not discussed in the treatment, something called a 20-20-20 regime, which we frequently use because these patients don't blink much. So as a clinical adjunct, I'll say that try using a 20-20 regime. Ask patient to look 20 feet away, blink 20 times in 20 seconds. It works. Something about ultra high resolution OCT. It has been used to image both the upper and the lower tear meniscus. We all discuss lower tear meniscus. We never discuss about the upper tear meniscus. But this is something which can be more objective. And a measurable increase in tear meniscus volume was evident after 1 month of treatment as claimed by this journal. Now this is something interesting, ribamipide. This is a GI protectant drug. None of the article gives its exact mechanism of action, but it has been found that it is effective. The percentage which should be used is 2%, and it is a well-tolerated drug. Most importantly, it claims that it can restore the microstructure of the tear film and the corneal epithelium. And people have suggested it to be used as the first drug of choice for severe dry eye. And almost in a large sample size, 154, they found it to be well tolerated after 1 year use. And you'll be happy to know that we have an Indian endorsement on this drug. Dr. Vajpayee has used it. Something called 3% dicofosol. This is a P2Y2 agonist. Partial improvement occurred in few patients, about 2014 research. Another one found that 76% patients responded. So still now this is in infancy. The drug definitely shows a change in the Rose Bengal staining score when compared to the other agents, and it has been found to be superior. But what does it mean clinically? Can we advocate it? Answer is still no. It is being promoted by Santin. Now, there are few drugs which have come in and gone out. This is tofacitinib. This is a Janus kinase inhibitor. Even the trials had to stop midway, though they claim that there were improvement in both sign and symptoms. But after 2012, this drug has not been heard of. There is something called lifitegrast, SCR118 integrin antagonist. This is a promising drug. There is something called a Opus 1 study going on. Till their phase 3 results, they have claimed it to be superior to the other newer agents. There is something called anakinra. You must have all seen if you are associated with a multi-speciality hospital. It's an interleukin-1 receptor antagonist. This drug keeps coming into our articles and going out since 2008. No recent buzz since 2013. And lastly, I'll talk about abdominal breathing, something which Indians can take proud of, but the article has not been published by us, by some Japanese people. They have a very small sample size. But they say that abdominal breathing for 3 minutes in a group of healthy women increase the tear meniscus volume at 5 minutes, 15 minutes and 30 minutes after research.
Thank you.
I think
Thank you.